Idaho Matters podcast is brought to you by St. Luke's On-Demand Virtual Care, which allows patients to see a provider from their home using a computer or smartphone with on-demand care for common ailments, such as a cough, sore throat, or a sinus issue. More information at stlukesonline.org.
At the Boise Art Museum right now, there are almost 1,000 hand-painted plates on display. The blue and white dishes show detailed illustrations of comfort foods like spaghetti and pancakes and hamburgers, the last meals of death row inmates.
You have to wonder what kind of life they lived for that to be the case.
I'm Julie Luqueta. Find my report and pictures of the Last Supper exhibit at boisestatepublicradio.org.
From the studios of Boise State Public Radio News, I'm Gemma Gaudette. This is Idaho Matters. The Centers for Disease Control is changing its recommendation for when to give babies the hepatitis B vaccine. The World Health Organization has weighed in on GLP-1 weight loss medication, and we're learning that some doctors say some cancers should not be treated. And you sent us a question about the flu shot. It's Wednesday, which means it's time for our Dr. Roundtable with Dr. David Pate, the former CEO of St. Luke's Health System and the co-author of the book Preparing for the Next Global Outbreak. Hi, Dr. Pate.
Hey, Gemma.
And folks, remember, if you have a public health question, send us an email at idahomatters@boisestate.edu. So, Dr. Pate, I want to start with the CDC changing its recommendation for when to give the hepatitis B vaccine to babies. Can you start out by giving us an overview of this change?
Yes. So I think what's key for people to understand, because this is where the confusion lies, is that hepatitis B is a virus, and most people think of it as a disease that is transmitted by having sex or using intravenous needles for drug abuse. And those two things are certainly the case for adults. And because of this conception, people don't understand why would we be vaccinating infants, because obviously they're not shooting up drugs and they're not having sex. But because they don't understand how differently the virus is transmitted to infants. And with infants, their first big risk is being born. When they come through the birth canal, they are going to be exposed to the mother's blood. And if that virus is replicating in mom, then it can infect the infant right there at birth. And unfortunately, when it does, unless that child, that infant receives the vaccine and immune globulin, then they are very likely destined for chronic liver disease, which eventually it can cause cirrhosis and liver cancer. And in a significant percentage of these children will shorten their lives. And the big problem with hepatitis B is that you often don't develop symptoms when you are chronically infected until you're developing these end-stage complications. So what the United States did is, prior to 1991, we used to take a risk-based approach. That is to say, Gemma, if you're having a baby, we're going to check to see during your pregnancy if you have a test for the presence of hepatitis B. And then if you do, we're going to vaccinate your child when it's born. So that's how we did it prior to 1991. The problem was we missed a lot of cases, and we missed them for lots of reasons. First of all, as we are well aware, not all women get adequate prenatal care. Second, that test in the United States is typically done early on in the pregnancy, and we're terrible at predicting which women are at risk for hepatitis B, and therefore they might very well have been negative at the beginning of the pregnancy, but they may have become infected before the end of the pregnancy. And there are other factors why this slips through. The other thing that this doesn't account for is the other way that babies get infected with hepatitis B, and that is from household contacts that may, like I said, you don't know if you have hepatitis B until you develop problems most often. So, a household contact that has it, or unfortunately, in our day and age, a lot of these moms have to get back to work. That means somebody else is going to have to take care of the baby. That might be childcare, where other children could be there, and children bite each other, children swap saliva and stuff. They're putting their fingers in their mouth and objects in their mouth all the time. And even nannies, babysitters, grandparents, others who care for the infant, they can transmit the virus to them because the virus can be transmitted in their saliva. It can be on surfaces, and it can last for up to a week on surfaces and infect the children. So in 1991, we moved to a universal recommendation, which was vaccinate every child. And cases dramatically dropped back before we made this change. My recollection is there were something like 16,000 cases of hepatitis B a year. In this most recent year, that was a report, I think that we had data for, I think it was 23, there were like 7 cases. So we're making this huge difference. But the vaccine committee recommended, without any good scientific basis, without any safety signals or safety concerns. And keep in mind, we've been using this vaccine for 34 years now. We have lots of experience with it. We know it very well. They decided that unless the mother tested positive or we didn't know, then you should not recommend that birth dose. They need to just talk to their physician. And of course, that's going to mean that people don't get that first dose, and we're going to delay it. And like I said, mothers are not the only way that babies get infected.
So, Dr. Pate, with all that, what are you worried could happen if babies aren't getting this vaccine at birth?
Well, what we know will happen, because we have history, is that some of these babies will get infected. The chances when you get infected, the chances that you'll develop chronic liver disease are highest at birth, and they slowly decline over your lifetime. So if an adult gets infected with hepatitis B, they're going to be much less likely to develop chronic disease. It still happens, but an infant is the highest risk that it's going to be, close to 90%. So what's going to happen is that, number one, there's going to be babies infected, and we're going to see this again, which is a terrible shame because this has lifelong health consequences for that child. Number two is this is all more part of shaking confidence in our vaccines and our public health, because like I said, a lot of adults, it doesn't make sense to them why we vaccinate babies. We have a really good reason for doing it, but it doesn't make sense based on what they know. And now with this change from the committee, there's going to be a lot of people who think, oh, well, maybe we should be reconsidering giving this dose, and maybe there is a problem. And then, of course, third is that I generally am a cup half full kind of person, and I typically don't try to go down dark paths. But I do think there's ample evidence that what this is, we just saw the opening blow to further disruption of the childhood vaccination schedule far beyond hepatitis B. This was just the first shot because, frankly, this was probably the easiest. I think we're going to see disruption to a good part of the schedule, and I think this is going to mean we're going to have more kids with vaccine preventable illnesses and the complications thereof. And I think it's a shame that in this day and age of all the advancements we've made, that we're not a little bit more enlightened.
Mm. I want to switch gears now and talk about a recent article out of the New York Times. Fascinating, Dr. Pate. It's saying that some doctors are saying that we should not treat some cancers. So, what kinds of cancers are we talking about?
Well, the classic example here has been prostate cancer. For decades, we have argued about should we be aggressive in treating all prostate cancers? And the reason is because first of all, it said, now this is an exaggeration, it's not exactly true, but if you live long enough, you'll get prostate cancer, has been the mantra.
Mhm.
And the point is that when men die at old age and they're autopsied, we very frequently find they have prostate cancer, but that is rarely the cause of their death. And so what happened when PSA testing came about is we were picking up on a lot more prostate cancers and a lot earlier, and we were giving aggressive treatment to men. That treatment, radiation surgery, it could lead to impotence. It could lead to urinary incontinence. There's certainly challenges that can come from that. And the question is, was it worth it to treat their prostate cancer? Because while prostate cancer can be very aggressive in some populations and can kill men, in older men, it tends not to be as likely to do so. And so prostate example is the main example. What this article is referring to is an increase in some cancers that we've seen over the past few decades, but we haven't seen an increase in the mortality rates, raising the question, yes, we may be finding more cancers earlier, but should we treat them? And probably the next best example of that would be thyroid cancer, which oftentimes is fairly indolent. There certainly are aggressive forms of thyroid cancer, but those are the minority. But they also found an increase in kidney, small intestine, pancreas, a blood cancer called myeloma. Now, that article does mention a couple of cancers that I for sure do not believe we should just ignore, and those would be colorectal and endometrial, because those, in fact, have had an associated death rate with them. But I think that there's a lot of questions. One, so over the past few decades, what has changed that we're seeing these earlier cancers? Well, one big question is toxins in the environment, and specifically what we've become more concerned about in recent years is so-called microplastics and PFAS. And I really wish that RFK Jr., and this would be right up his alley as an environmental lawyer, would spend more time with the Department of Health and Human Services funding studies and looking at this issue instead of vaccines, which we already know the answers on. Another factor that could be explaining it is obesity, because we have identified now at least 8 cancers that are associated with, your risk for them is increased if you have obesity. And of course, obesity has been rising. Another subject that you and I have talked about a number of times is these ultra processed foods. And are they causing a change in the so-called microbiome, the makeup of the bacteria in our intestines, that may be influencing risk for cancer? So these are all questions. I think one thing that the article left out that I would certainly add is the other thing that has happened is a whole lot more people getting imaging, like Kim Kardashian going out and saying, everybody ought to get a total body MRI. Certainly doctors are doing a lot more imaging, but there's a lot of people going out, and you can buy these scans and so forth. And when you do these scans, you do find things. And the question is, are we better off knowing about it, or maybe we're not better off knowing about that?
Well, so here's what I also found interesting in this article, Dr. Pate, and maybe you can talk about this as well, is it's exactly that. With the imaging, they're finding cancers so much earlier. And they cited something that happened in South Korea, which is that they started scanning, younger people, because we're seeing more cancers in younger people. And what they found out was that for all but 2 of these 8 cancers, colorectal and endometrial cancers, even though the incidence of these cancers soared in younger people, death rates are flat or declining. I think there's a quote in here where it says we're a very image happy society. One of the doctors said, who was interviewed. So my question is this: I would want to know at a very early stage if there was cancer. So what do we take away from this if the idea is, well maybe you wait a while and then if you have it, we treat it? That just seems to be almost counterproductive.
Right. And I'm not sure I really agree with the approach of the article. What I would say is this is a call, again, to RFK Jr. and the National Institutes of Health, that instead of a lot of the nonsense that we're engaging in right now, let's do a lot of research here. This is a great opportunity, in my mind, to understand the evolution of cancer, the genetic risks of cancer, the biological characteristics of cancer. How are doctors to be able to evaluate, oh, we have found this cancer, but we can tell you that this is not going to be one of the cancers that's going to affect your health. So we can observe it. We don't have to go in. Maybe, Gemma, again, go back, think about it being in the reproductive years. A lot of the chemo we give could end your fertility. If we could tell you that, okay, well, we happen to find this cancer, but we can tell you that this is not going to be a problem. Let's watch it. You can go ahead and have your kids do that kind of stuff. Then, we'll reconsider at that point. But we need studies to understand what is the significance of these cancers? They have cancer for a reason. What is the reason, and why would some cancers behave in an indolent fashion and other cancers could be quite serious? How do we tell the difference? How should we manage them? What does that mean for the risks for family members? This is ripe for research, and we are not researching it. We're spending our time saying, well, we ought to go back and do studies on vaccines that we already had 50 years of experience. That's not going to help us. What we need is answers about these kind of things. These are the real issues that could be useful to the American public.
So, Dr. Pate, we got a voicemail from a listener. Let's take a listen to this.
Hello, Dr. Pate and Gemma. This is Julie from Boise, and I'm calling because I received my flu shot yesterday. I wanted to alert your audience that at least at Albertsons and in our local region, it looks like the high-dose flu zone is unavailable. So because I'm a senior, that's what I requested, but they do not have it. Thus, I received the regular flu shot. Can you please discuss the differences as well as the protection of one versus the other? I so appreciate you. Thanks so much.
Okay, so Dr. Pate, thank you, Julie, by the way, for that voicemail. Can you tell us the difference between the shots that Julie was talking about and then the efficacy for them, I guess, depending upon your age?
Yes. Well, Julie, thank you so much for calling in with that comment and question. For listeners that are interested in this, I wrote a blog piece that goes into a lot of detail about this a couple of months ago that goes through all of the different vaccines for influenza so that you can answer your questions. But let me answer Julie's. So, Julie is very knowledgeable that once you're over 65, you do need something other than the regular influenza vaccine. And that's just because us old people don't have as vigorous an immune response to the regular flu vaccine at this age. So there are three options for those of us in that over 65 category. One is the one that Julie mentioned, high dose, and that one goes by the trade name of Fluzone. So what that is it's about 3 to 4 times as much vaccine antigen as you would get in the regular shot, because it gets us up to the immune protection that younger people would get. But there's two other choices if they don't have the high dose that I write about in the blog. One is the other trick you can do. Rather than increasing the amount of antigen 3 to 4 times as happens in the Fluzone, you can just get an adjuvanted vaccine, which means that we've added something to the vaccine that just kind of shakes your immune system and says, hey, look, we're right here, come after us. And it picks a fight with your immune system, so you'll get a good response. And so that's an adjuvanted vaccine. And the one that we have available goes by the name of Fluad. Then the third option is that you can take a recombinant vaccine. That's where we take the protein that we use to trigger your immune system, and we make it synthetically, so it's really strong, very precise, really triggers that immune response, and that one is called Flublok. So any of those three are adequate. I don't know of any studies showing one superior to the other, but the key thing you should know is if you're over 65, you do need one of these three to get the best response. It's the same vaccine. It covers the same vaccine strains. It's all the same as the regular vaccine. It's just amplified so that us seniors will get better protection.
So, Dr. Payne, I also want to talk about the World Health Organization, because it's released its recommendations for GLP-1 drugs. Now, as a lot of people know, these are drugs that started out to help diabetes patients about 20 years ago. They are in use now to be helping people who are struggling with obesity. So what did the World Health Organization say about this class of drug?
Well, I was very happy to see the World Health Organization come out on this. Obesity is a disease. A lot of people still think of obesity as people with poor willpower or self-control. We know that's not the case. The body, we know that there are actual biochemical and cellular changes that occur with obesity that, frankly, undermine your efforts to lose weight. And so most everybody knows from yo-yo diets or where you've worked real hard to lose the weight, but then it just comes right back. The body resets itself to try to preserve that overweight condition. And so GLP-1 drugs have been a real game changer. And I have to say, there's never been a drug introduced to the market in the time that I've been practicing medicine, since the 80s, so almost 40 years now, that it has surprised me as much about all the things that it can do. That is not to say that it's not without risks. It is, but it is a really helpful medication in the battle against obesity. Now, with that said, what the World Health Organization came out and said is exactly what I counsel people about that are thinking about using them. First of all, you should not look at GLP-1 drugs to be the cure all. It's not the magic
Mm.
drug. It's not that you can just take it and then do whatever you want. So it's really important that you use the GLP-1 as an aid and assist, but now it will help you get over certain cravings. It will help you get to the position where you're getting positive reinforcement by seeing the productive changes. But you have to couple that with improving your diet and exercise. And one of the big downsides to GLP-1 drugs is they will contribute to a lot of weight loss. But if you do not do exercise, and particularly what we would call resistance training, you are going to lose muscle mass. And that's not in your long term best interest. And in fact, in some people, especially older people, where we've seen them overly rely on the GLP-1 drugs, they develop a very serious problem that's called sarcopenia, meaning that they've lost so much muscle mass that yes, they've lost weight, but they also now have become weak, prone to falls,
Mm.
don't have the strength that they need. So the World Health Organization is saying these are great drugs. They certainly should be considered, but it's not the be all end all. You need to couple that with diet changes, exercise changes, particularly resistance, and they also make the plea for equity so that
Mm.
we know these drugs are expensive, so it's not just the rich nations getting access to this medication.
Well, and Dr. Pate, the thing too is, how about how this would potentially impact insurance coverage? I'm not sure if you can speak on that or not, because many insurance companies in the United States are dropping their coverage of GLP-1 medication unless you've been diagnosed with diabetes. But we have the World Health Organization. We've had, I believe, the American Academy of Cardiologists coming out and saying that if someone suffers from hypertension or heart issues, that a GLP-1 should be a first line of defense, right? So how does this change the conversation, not just around GLP-1 medication use and it being covered by insurance, which would then make it more equitable, but also the fact that obesity is a medical problem. It is not because someone cannot put down a fork.
Yes, this is a really good point, Gemma. They are expensive. I think that this needs to be one of the areas that our country, our government focuses on price controls to get this reined in. But the problem is, if I were advising an insurance company, which I'm not, I would tell them that, there are so many health benefits associated with this that we really need to think about your mission and what you want to accomplish, because not covering this drug is going to mean you are taking away one of the most powerful tools to help improve people's health. Now, the problem for insurance companies is that we are all changing our plans every year or two. And so the problem is an insurance company could say, okay, we'll cover the drug. And eventually, of course, your healthcare costs are going to go down because you're going to improve your health. You might get off of insulin. You might, improve your heart disease, et cetera. But then they're worried, well, it's going to be another insurance company that reaps the benefit of that. If we cover it now, we won't. But frankly, this problem is so pervasive that if they would all agree to cover this, they would end up all sharing in the
Mm.
benefit.
Well, and wouldn't that be nice if they could do something like that? Um, do, Dr. Pate, as always, we so appreciate you. And remember, folks, if you have public health questions, you can send us an email, idahomatters@boisestate.edu. Send us a voicemail as well, like Julie did earlier today. But again, a big thank you to Dr. David Pate. He'll be back with us next week. He is the former CEO of St. Luke's Health System, as well as the co-author of the book, Preparing for the Next Global Outbreak. Again, if you have a public health question, our email address is idahomatters@boisestate.edu. And that'll do it for this episode of Idaho Matters. Thanks so much for listening. And just a reminder, you can find all of our episodes wherever you get your podcasts.
How does AI even work? Where does creativity come from? What's the secret to living longer? TED Radio Hour explores the biggest questions with some of the world's greatest thinkers. They will surprise, challenge, and even change you. Listen to NPR's TED Radio Hour wherever you get your podcasts.